Okay, can everybody hear me? Great. So my name is Roald Otten. I'm a physiotherapist at Aspetar, and I'm going to tell you a little bit more about the assessments we do as a physiotherapist and what kind of treatment we can do. Before I start, I want to do special thanks to Andrea Mosler. She helped me with this presentation. She gave me some of the pictures that I'm using. She's a PhD candidate at Aspetar, and she does a prospective study on groin risk factors in Qatar football players. All right, assessment. So as physiotherapists, we look at a lot of things. We can do pain provocation tests. We can look at the range of motion, the flexibility. We can look at the strength, of course. And we also do a lot of functional tests. But I only have 15 minutes, so I cannot go into the functional tests, but I'll try to tell you a little bit about the other things. One of the things that we almost always do with our patients is squeeze testing. Dr. Sarko already showed this, but as physiotherapists, we do it slightly different. For this, I have to invite Nicole again, because I'm going to give a small demonstration. The squeeze test we are using to monitor the progress of the patient. So, for example, a patient with adductor-related groin pain, you get them for initial assessment, and you want to know a status. You want to do a baseline measurement. We put the patient in supine. We can do either in a straight leg squeeze test, or if we want to isolate, like Sarko was telling us, the adductor longus, then we put the hips in 45 degrees of flexion. We put the feet together, and we use the, I don't know, where's the camera? We use the handheld dynamometer for this. It's a very practical device that gives us the strength in either newtons or kilograms. In this case, we use newtons. We put the device around the hand, and we ask the patient to squeeze inside. But we want to know two things. We want to know the P1 and the Pmax. The P1 is the strength, the power that the patient is giving at his or her initial pain. So what I explained to the patient is that you need to slowly push into my hand, yeah, stronger and stronger, yeah. And when you feel your first pain, you stop and you tell me, all right? All right, and go slowly. Tell me when you feel your first pain. Okay, and relax. We can review the score, and for example, he is pain-free, I believe, right? But your P1 could be 88. Then we do it again, and we ask the patient to give a maximum contraction. So slowly build up and go maximum. Come on, come on, come on, push, 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 and relax. You have to yell a little bit with it. It works. So in this case, 239. Yeah. So the P1 was 88, the Pmax was 239. But then we also ask the patient the amount of pain. So we use a numeric rating scale for pain, so between 0 and 10. So how much pain did you have? 8. 8. Oof, mushkila. Okay, so that's one of the main tools we use with patients with adductor-related groin pain to monitor their progress. You can stay there and relax a little bit. We also measure the range of motion. I'm not going to show that because I have limited amount of time, but you can do this with a goniometer or inclinometer. Could be an analog or a digital, as you can see in the bottom. They're all reliable ways of measuring range of motion. We in general do it in supine, in 90 degrees of hip flexion, and in prone, where you can easily measure both range of motions of internal rotation at the same time. There's a good correlation between injury and internal rotation. There's no correlation between external rotation and injury rate. We also do the bent knee fallout. We measure the flexibility. This is again a really nice tool to measure progress during your rehabilitation, as a lot of these patients have muscle tightness or reduced flexibility in the adductor longus. And by measuring on a, no, I wouldn't say on a daily basis, but on a regular basis, measuring the distance between the table and the fibula head, you can really nicely see if the patient is progressing or not. Then I think one of our most important things that we do as physiotherapists is assessing the strength of a patient. So I will demonstrate that on our subject. For this we go in side lying. We test the abductors and the adductors in an eccentric manner, so we do a break test. Yeah, the break tests have shown to show better correlation with pain. We first do the abductors. The leg that is on top we are testing. The other leg is flexed 90 degrees in the hip and in the knee. The patient is stabilizing here on the table with his hand. Make sure that the hips are exactly above each other, and because patients tend to roll backwards, and then you're mostly testing hip flexion instead of abduction. We stand at the end of the table. So Nickel, you have to push against my hand, so you go with your leg towards the ceiling. It's very important that you keep your foot horizontal like this, so don't external rotate. No, keep it like this. Yeah. You're going to push against me, and at the end, after I'm saying 3 times push, I'm going to push you down, but you still try to win. Okay? You ready? And go. Come on. Push, 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 and relax. This is where we test the abductor strength. He's quite weak, but it's okay. It's just to show them. The adductors, we do in the same position, only the other leg, the top leg is flexed now in 90 degrees in the hip and in the knee, and the bottom leg is straight. With this test, or with this testing positions, patients tend to flex their knee and use their hamstring, but we have to prevent that, so we ask the patient to contract the quadriceps. We stay in side lying, don't rotate backwards. Yeah? And the starting position is a little bit in extra adduction, because if we start here, yeah, we can push into the table, and we're testing the strength of, you're testing your own strength, how hard you can push, and not the strength of your patient. So we bring in some adduction. Again, the same thing, Nickel. You ready? And you go push, 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 and relax. Great. 202. Not bad. All right, that was it. Thank you. So this is a really good and reliable manner to test the strength of your patient. We're now at the Handball conference. Unfortunately, we don't have any data on the strength, normal strength ratio for handball players. From the screening that we have done here in Qatar with all the football players, we know that in healthy football players, the adduction, so the inside-outside ratio is 1.3. So we want the adductors, ideally, 30% stronger than the abductors. So I don't think we can use this with the handball players because they have completely different loading patterns. Of course, it's direction changes, but also with ice hockey you have a lot of direction changes. But there, the ratio in healthy ice hockey players is 0.95. So if any of the handball people here have some data on this, please share it with us. Okay, then we go to the treatment. Broadly saying, we have 2 types of treatment, 2 types of therapy: exercise therapy and hands-on therapy. For the exercise therapy, we are still using the Holmig protocol. In the handout that you received, you can find it. It's this one with the guy with the yellow shirt. In this protocol, or the study of this protocol shows very good results. 79% of the subjects returned to play. But what we have to say is that it's only after 18.5 weeks. So is this the best? Yes, at the moment it's the best we have. The protocol consists of 2 modules. Module 1 you perform in the first 2 weeks, and module 2 from the 3rd week. In module 1 we do squeezing with straight legs and with flexed legs. We put a football between the feet or the knees, but with handball we probably use a handball. We do some sit-ups. We do a folding knife sit-up exercise in the bottom left, where the patient is squeezing the ball and at the same time is doing a knife-like movement, a sit-up. We do some wobble board training, because in this program they also try to incorporate the whole core. And in the last exercise from module 1 is the gliding exercise, the lateral gliding exercise. With this exercise it's very important that you put good pressure onto the gliding object that you use. In this case it's a towel. But you have to put good pressure, like you're trying to clean the floor. Yeah? You keep your knees straight, you glide outside until your hips are about in an angle of 90 degrees, and then you pull back in. So after the 3rd week, or from the 3rd week, module 2 starts, where we do side-lying abduction and adduction. We do back extension. We do theraband elastic adduction and abduction. We continue with the sit-ups, and we do Pure Holmik's favorite exercise, and that's the CrossCountry Ski exercise. And everybody's always doing it wrong, so I have to show you. Okay, so what he wants is that you move your arms forward, backwards, like this. You make a very big movement. And then, whenever your hands change position, yeah, you make a small single leg squat. If you have control doing this, you slowly go faster and faster and get like a rhythm. Yeah? So hopefully from now on nobody does this the wrong way anymore. Per will be very excited to know this. We also do the fitter exercise in the right top. We continue with the wobble board exercises, and we do skating movements on the skate plank. This program is set up in 2 modules, and I must admit that as a clinician I'm not always doing it this way. Yeah, I think you have to also use your clinical reasoning and be smart about what you're doing, and maybe choose a little bit more gradual progression with the exercises. The exercises are great, but yeah, in a clinical setting, you adapt, of course, to the patient. So what I just shown you is the official protocol from the 1999 paper. We also developed a home protocol, which is almost the same, but as you have seen in the previous slide, 2 of the exercises, the fitter and the skate plank, not everybody has that equipment, not everybody can do that. So we developed an at-home program. It's almost the same, yeah, it's in your handout, and we developed an app with it. With a QR code, which you can scan, you go directly to the app, and it's also very convenient for your patients. Yeah, you can give it to them, they can do it, and they can see how they have to perform the exercises, because if you click on the different exercises, you get a video. All right, last thing, Handson Therapy. I need Nickel again for this. You can do all kinds of Handson Therapy, and I don't want to bore you with that, but there's one therapy, a manipulation that I find very effective. I use it with most of my adductor-related groin pain patients, and I have really good results. Colleagues of mine in the Netherlands, Rob Langhout and Igor Tak, are currently doing a prospective study on this manipulation, and yeah, we are waiting the results. They're still in the process, so hopefully in the near future we'll know if this is really working or that I just have the feeling it's working. So what do we do for this manipulation? We're going to put the patient in supine. We put a towel or something else under the knee, so we have slight abduction and flexion in the hip. We palpate the adductor longus muscle. We ask the patient to squeeze inside a little bit so you can find out where it is. Okay, relax again. Then with one hand you grab the proximal part, and with the other hand you just grab the muscle underneath, and from there you do some tractions and some translations. And Nickel doesn't like it. It should be quite painful, but you can imagine that patients don't like this at all. Some tractions again and some translations. You do this for about 10 seconds. It's really short. Then we go to the Faber position to do a stretch. Is this comfortable? Do the stretch for about 30 seconds. Okay, so 30 seconds have passed. You put the patient back in the starting position, and you do like 30 seconds of a little bit shaking the muscle, soft tissue, just to get rid of that pain, because it's quite painful. And you repeat this 3 times. If you do this, in general, we do this once a week. And yeah, I find it very useful. I would say try it and you will see. Thank you. That was the end of my presentation. Thank you.